Word on Health, the report with its finger on the pulse of popular medicine, with Paul Pennington. Word on Health, for your very best of health.
Hello and welcome to this edition of the Word on Health podcast with me, Paul Pennington. Coming up, I'll be talking to the clinical lead of Diabetes UK, Douglas Trenefor, and I'll be joined by Mandy Malcomson from the Strathcarron Hospice. But first, more than 340,000 people across the UK are living with bronchiectasis, making it one of the country's most common chronic lung conditions. Yet many of us have never heard of it. Left untreated, it can be life-threatening, and deaths from it have increased by 40% over the past decade. A new report warns that delays in diagnosis and unequal access to specialist care are leaving patients sicker, increasing avoidable visits to A&E and placing an ever-growing unnecessary burden on the NHS. Here to highlight what bronchiectasis is, why it's so often missed, and what needs to change is Professor Tony de Soyza, Professor of Pulmonary Medicine at Newcastle upon Tyne Hospital's NHS Foundation Trust.
It's an umbrella term. It basically means a combination of a widened airway on a CT scan with somebody that's coughing up more mucus and phlegm. It's almost like the business class upgrade of bronchitis that never really goes away. And the confusing thing a lot of people have is that patients with asthma, which affects 1 in 10 of us, and COPD that affects nearly 1.5 million people in the UK, can also have this condition. So you can have the symptoms of asthma and COPD and they get a bit worse. And then that leads to us thinking, oh, there's some bronchiectasis here as well.
Tony, why do you think awareness of it is so low?
It's been very much a neglected condition. There hasn't really been a clear focus on it in terms of research. Asthma and COPD, really common and important conditions, have quite rightly had attention. But also, I think it's because we really didn't understand the condition well. We used to think predominantly it was a condition where you were prone to infections, which patients are. We're increasingly recognising inflammation and abnormalities of this thing called the microbiome, with a little community of bacteria that live in our gut. We have similar ones in the lung. They become abnormal and irritated. So we've only learned some of those other areas fairly recently, so it's definitely behind the curve.
What are the risk factors?
It can affect anybody at any age, so we definitely inherit patients who are growing up in my adult service from paediatrics. So if you're born premature and had severe lung infection as a child, you're at risk of that. There are some genetic causes, and one of the sort of confusing things is that the genetic condition called cystic fibrosis that people are aware of, effectively they have bronchiectasis in their lung and other conditions outside it. You can get it because it runs in families, and then, as I mentioned, that you can see it in patients with asthma and COPD, but other conditions that are put you at risk are where there's uncontrolled inflammation or abnormal immunity. So rheumatoid arthritis is more likely to have bronchiectasis as a complication in the lung. People with inflammatory bowel disease like Crohn's or ulcerative colitis. And we also see it in people with swallowing difficulties. If your swallow's abnormal, you inhale bacteria into your lung, then you're at risk of that. So quite a really broad range. And if you have immunodeficiencies as well, you could see how that would play into the system. So quite a lot of causes. So the clinics are always interesting and challenging because there's a bit of detective work to be done.
You talk there about detective work. Is there a delay in diagnosis because clinicians think of more prominent conditions first?
Yeah, it's a brilliant question. Lots of patients talk about a really long delay. I understand why that would happen. My suggestion is that we take a pragmatic overview. If you have cough, wheeze and phlegm, it's very reasonable to assume that could be asthma or COPD. But if you're not responding, or if you've got really high volumes of mucus, more than a sort of teaspoonful or tablespoonful a day, then you should start to ask the question, could this be something else? And do I need to get a scan or referred for something else?
Are there effective treatments that can help?
The evidence base is not as robust as we'd like it to be, but basic tenets of good care certainly are. We now recognise that the patient voice is really important here. Patients have told us for years if they get shorter courses of antibiotics, which were often used in asthma and COPD, they just don't seem to work as well. So a longer course of antibiotics if you've got a flare-up. We think that physical therapy is good for you. Coughing exercises, which help get more of the mucus that's trapped in there out, are really key parts of it. And then there are other therapies like long-term low-dose antibiotics in a nebulizer and a mist, and there are other therapies that are coming to the fore that tackle inflammation. So quite a lot's going on in the field. Patients that are involved with bronchiectasis clinics are really heavily engaged in research, was fantastic because they are actually championing their own treatment and their cause, which is fantastic.
Give me a brief overview of this new report by the Bronchiectasis Policy Network UK that you're chair of and what you're calling for.
The report was about how we felt that bronchiectasis had been left behind. It was a multidisciplinary team, including physios, nurses, patients, and consultant colleagues. And what we found was that we actually have quite a lot of the tools to give good bronchiectasis care in the NHS, but they're not being applied consistently, and patients are suffering as a consequence of that. What would be fantastic is that we were included in national quality standards, that we were considered as part of the shift from hospital to community, so making healthcare more accessible to patients. Because at the two bookends of it, if you've got early mild disease, that can cause quite a lot of concern and consternation. Actually, with good basic care, we can get people feeling great and on a steady path. And at the other end, the more severe patients, some of those more severe patients have really quite bad outcomes. So the middle group are the people that we want to obviously shift to the left and keep them well. And the group to the right, we really want to get them sorted out, aggressive therapy as well as possible. And I don't think we've cracked that yet. So working together with patient stakeholders, funders and organisations is really a key for me.
My grateful thanks to Professor Tony D'Souza. To find out more, visit wordonhealth.com. That's wordonhealth.com.
Word on Health, for your very best of health.
Across the UK, over 4.3 million people are diagnosed with diabetes, with around 90% of those cases being type 2. An estimated 1.3 million additional people live with undiagnosed type 2 diabetes, and approximately 6.9 million people are thought to be at high risk, having pre-diabetes or increased blood sugar levels. With cases continuing to rise, including among younger adults, recognising your risk and taking action early could help prevent serious complications. Yet new research from Diabetes UK and Tesco suggests that most people have never checked their own risk, and many don't know how. Douglas Trenefor is head of clinical with Diabetes UK.
We would have expected that more people would be interested in checking their risk and getting the support to do something about it, because we have known for quite a while that with a few steps, many people can either delay getting type 2 diabetes or actually prevent it completely. But there are still some misconception around who gets type 2 diabetes, which is why any opportunity for us to raise the awareness of how serious type 2 diabetes is, we take that opportunity to do so.
What are those misconceptions?
It used to be a condition that was associated mainly with older people. Now we are seeing more and more younger people developing it. And the key is that if you develop it, say, in your 40s, you live with the condition longer. And your risk of developing complications such as kidney diseases, heart disease, stroke, amputation is higher the longer you live with the condition, which is why any opportunity to delay it or eventually prevent it is the best way to go.
Before we go any further, we're focusing in this report on type 2 diabetes, but of course there is also type 1, which research shows people often get confused about. Can you explain the difference between the two?
There are key differences between the two. We know that type 1 diabetes develop when people do not produce any insulin at all. And insulin is what the body needs in order to get the goodness from the food we eat, which turns into sugar in the blood. Without insulin, your body tends to store more sugar in the blood, and over time, that can have some serious health effects. For type 2 diabetes, people do produce some of the insulin I mentioned, but either they are not producing enough or the insulin they are producing is not working as effectively as it's supposed to. So both conditions have a lot of similarities. The similarities include without the support to manage their blood sugar levels, their risk of serious complications are high.
As I said in my introduction, your research shows that many of us don't know how to check our risk of type 2 diabetes. It is a complex condition with risk factors beyond being overweight, and I know you'd encourage everyone to check out if they are at risk, and Diabetes UK offers a very simple tool for us to be able to do that.
There are different ways that you can check your risk, one of which is our Know Your Risk tool, which is online, and that takes a few minutes. It's a validated tool to be able to predict your risk of getting type 2 diabetes in the next 10 years. But within the NHS, there's an ongoing NHS checks which usually is for people between the ages of 40 and 74 who do not have any pre-existing long-term condition, and your GP will check your sugar levels, your blood pressure, and it will be able to tell you if you're at high risk of getting type 2 diabetes. If you are picked up as having high risk of developing type 2, there are support. So I will encourage everybody to be interested in checking either on our website, or if you're between the ages of 40 and 74, ask your GP for that check.
My grateful thanks to Douglas Trenefor. To find out more and link through to Diabetes UK to check out your risk of developing type 2 diabetes, visit the wordonhealth.com website. That's wordonhealth.com.
Word on Health for your very best of health.
After someone has been diagnosed with an incurable life-limiting condition, there's not a single linear end-of-life pathway. Palliative care, which can be general or specialist, is increasingly intended to start alongside disease-directed treatment, rather than only when treatment stops. The exact services vary between England, Scotland, Wales and Northern Ireland, and within each country. Hospices across the UK provide invaluable help and support for patients and their families. Yet, research shows there are a number of myths and misconceptions about them. Mandy Malcomson is from Strathcarron Hospice. Mandy, welcome to the podcast. To start with, tell me a little bit about yourself.
So I'm a palliative care nurse, but I lead a team and we call ourselves the Live Your Life team. It seems like a really weird title to have in a hospice when we're talking about living and not dying. So as we go on to chat today, Paul, what's important to me is to raise awareness of trying to access earlier palliative care. And that might be a surprise to people because palliative care is always associated with right at the end of life. But I'm here to try to bust that myth a little bit.
Many people, as you've just said, associate hospices only with the final days of life. What does a modern hospice actually do?
I like to think of modern hospices are really buildings and hubs. And within those buildings and hubs are teams of people skilled in delivering really great palliative care. And not only that, but another important aspect for most hospices is to be able to teach other healthcare or social care professionals, or indeed the wider public, in all aspects of palliative and end-of-life care. In many ways, I have to answer the question, what is palliative care? Palliative care, to me, is the alleviation of symptoms that might be affecting anyone with a life-shortening illness and their family, not just the person themselves. And that can be any sort of symptom. So it can be a physical symptom. It can be something like pain, nausea, breathlessness, fatigue. It can be a functional symptom, so potentially a decline in mobility or the ability to eat or drink. Importantly to me in the work that I do, there are emotional and spiritual symptoms. So it's really difficult to manage uncertainty, and people worry about what's going to happen to them, not only for themselves, but for their families. So when you think of palliative care as a sort of a wide spectrum, the end of the life is right at the end of that spectrum, but it starts much earlier. And so therefore, we need to start much, much earlier so that people can access the support when they need it and not when we decide they need it.
And of course, hospice services can be delivered at home, in a care home, as a day patient, as an inpatient, and people can move between these according to their needs. One of the biggest misconceptions is that accepting hospice care means giving up. Why isn't that the case?
Understandably, people are really scared of the word hospice. I think they've all had some story connection with the hospice. And for us at Strathcarron, it's a beautiful building and beautiful grounds, but it's at the top of the hill. And a lot of people think, oh, that's where people go to die, or that's where they go when they come out in a box. And that's very much the conception of what people know about hospices. But I think things have changed over time, particularly over the last decade or so. I like to think of hospice care as walking alongside someone and offering whatever it is to bring a decent quality of life for the time that person has left on the planet. And for many, that can really be quite a big stretch of time, Paul, enough to sort of get things done. So when you're talking about giving up, actually, I would challenge that, because actually when you're walking alongside someone, you're actually able to say to them, right, what is it that you're still trying to achieve? What is it that you want to get done? What is it that you need to say to people that you maybe haven't thought about before? So it's actually giving people encouragement, reassurance and tools to not give up, but to actually get on with life and deal with this life-shortening condition.
How does the level of care and support you and your colleagues at Strathcarron provide compare to the other hospices across the UK?
I think it's similar. I think all hospices are really under the same ethos. We're here to alleviate symptoms, physical, emotional, spiritual, as someone is heading towards the end of their life, and that can be quite prolonged. So I think in most situations, hospices are really hitting the mark with that. I think that is what we're here to do, and that's what we're good at, dealing with uncertainty, helping navigate through a lot of difficulties with healthcare, helping them plan ahead to what they might want at the end of their lives. But actually, what about the gap in between that time? You still have to get out of bed. You still have to get on with your day. Healthcare professionals are not there 24/7. So we have to be able to work with people to give them the confidence and tools to be able to get on with things, but also know where there's a point of contact if they're running into bother. And I think most hospices across the land are trying to achieve that and to get it right for everyone, because we only get one chance to get this right.
The NICE guideline on end-of-life care reviewed the evidence and found that earlier referral to palliative care is associated with fewer emergency hospital admissions, fewer intensive care admissions, and a greater chance of dying in the person's preferred place of care. Yet research suggests many people are referred to hospice care by their clinicians much later than would be ideal. What's your view?
For me, that can be really tricky, because sometimes professionals, they're not skilled to talk about this practically to people and be honest with people. But also they might have that barrier of, oh, you're not ready for hospice support yet. You're not symptomatic enough. So there's the barrier. And I think that's the bit I would like to challenge healthcare professionals to really think about. Okay, if the hospice needs a referral from you, take one step back and think a little bit earlier down the track. Could this person benefit from a little bit of hospice support a little bit earlier so that they can start planning ahead and be in control?
All hospices across the UK are reliant on donations from the magnificent British public to keep going. Despite the financial challenges, I understand you and your colleagues at Strathcarron, as part of this modern approach to palliative care and support, have pioneered a new service. Talk me through it.
Well, I think we're in quite a unique position, but I'm hoping that it's one that might grow. So we decided just on the back of COVID that we would look at a service that would provide that earlier access to palliative care support. What we needed to do there was set up a new team, hence this wee team we're called the Live Your Life team. And that name came from a bunch of people that we support. They wanted us to focus on the living part. And we're predominantly a telephone support service. And that means we're able to deal with quite a large caseload, because we're not having people come into the building. We're not having to go to visit people at home necessarily, although we do. But it is that way of people being able to make contact with the hospice without the need for a professional referral. So they can just lift the phone and they can say, okay, I thought I would phone on behalf of myself, or more than likely than not, it's a family member, usually an elder daughter, if you can imagine. So people actually phone us up or they email us and they have a conversation with us in terms of, I would like to explore hospice support. Here's my story. We as a team, we ask 3 questions. What is important to you at the moment? What are you managing yourself? Because we can't fix everything. And what do you need our help with? That is our core conversation. And if that person then comes on board with us and we develop the relationship, then as things change for them, we can change with them and we can find out what other parts of our hospice are available to help support them. So Paul, this is the exciting thing for me, and I'm so pleased to be able to talk about this. This is usually quite a bit earlier in people's journey. And it's almost a tentative dip your toe in the water and find out all about what hospices do. But we're trying to get rid of the barriers to referral. And therefore, we have asked people to self-refer. It's amazing because it's happening and we didn't know how it would go. I think at the moment we're still the only hospice in Scotland that offer a self-referral service directly for support. So I think it's just really exciting times for us. We have a very big caseload, but people will say to us, okay, let's talk again in 2 or 3 weeks' time, or let's talk again in a month's time. If we think that there's change going on and we think, okay, things are starting to change here, we might say, we normally speak to you every 2 weeks, but I'll tell you what, I'm going to phone you again next week, find out how you are. So it is really, really flexible. It feels as if it's driven by that person. And because of that, they feel more in control of what's going on for them and their family. And certainly for the people that, the loved ones, I guess we call them family carers, those people have a point of contact with us. And then we can help them navigate what needs to be in place should things change. Sometimes things don't change for a long time, but what we're doing is just developing these wonderful relationships with people so that they feel and trust us to be able to plan ahead towards the end of their life and maybe think about what they would want and what they wouldn't want. Sensitive conversations like thinking about funerals, thinking about what they would want to have at a funeral, have a laugh about a funeral. If you know the Scots, you'll know that there's a lot of humour involved with that sort of thing. So I think that can only be done by a consistent approach of building the relationship. Within the Live Your Life team, we've got nurses, so we need to have clinical ears and eyes. But we also have a healthcare support worker and 2 very skilled creative arts facilitators within that team. We all come with different personalities and we all develop different types of relationships with the people, but we are there as a point of contact, but also to help people self-manage, find out what's changing, and to help them plan ahead. As you could probably tell that most of the support that we do, a lot of it's emotional support. A lot of it is just, how's things? How are you doing? To me, that's the question of what's important today. Instead of talking about how's the pain, how's your fatigue, all the rest, we ask people, how's things? How are you? And then what comes up next is what's important to them at the time. So can you see the shift in balance of where we're at? It feels very equal. It feels quite early, but early enough for people to plan what might be important to them in the long term. If symptoms start to emerge, sometimes physical symptoms or emotional symptoms, we deal with them as much as we can, but we work really closely with our colleagues within the hospice in terms of more advanced clinical nurses. Might be the chaplain, it might be our patient family support team, or it might be that we need to ask the GP or the district nurse what's their role, how they're involved. So we're working as a team inside and outside the building. So I think that's the way things have changed for hospice care. I think, and I can talk about Strathcarron, but it seems to be moving in the right direction because we need to be supporting people at home in their own communities with their community supporting them as well. It's everybody's business to get death and dying and bereavement right. And we're hopefully the catalyst to get that to an acceptable level in our society, Paul, because we're a growing elderly population. So we have to start thinking about this and making it more sustainable.
My grateful thanks to Mandy Malcomson from Strathcarron Hospice. To find out more, visit wordonhealth.com. That's wordonhealth.com.
Word on Health. On air and online 52 weeks of the year with Paul Pennington. Word on Health. Your personal prescription for your very best of health.